Nicola, before I introduce you, I sit on the board of ODI, and increasingly the world collaborates, and I think that's a good thing. And I'm delighted that we've been able to collaborate with Interact Worldwide on the piece of work that Nicola's going to talk about. Collaboration makes the world go round. So, Nicola, over to you.
Great, thank you very much. I really want to pick off from where Una ended her talk after, I think, having set the scene about maternal health vulnerability so well, and to focus on some positive solutions that we've been trying to look at, as Will mentions, in partnership with Interact Worldwide, who are an INGO focusing on sexual and reproductive health issues, and then in conjunction with their partners in Ethiopia, Malawi, and Uganda. So when it comes to question time, I think Interact colleagues will also be able to have lots to contribute. Okay, what I would like to do is focus on one piece of the social protection solution, so to speak, for safe motherhood, and that's to look at cash transfers. So both cash transfers that have safe motherhood components and others that are explicitly focused on addressing safe motherhood, and then to conclude with some policy and programming implications. I'm going to skip the first part of the talk because I think Una's set the stage so well. What I would like to do is just one of the things we thought about when we organized this event was to think through how we could start trying to build a bridge between communities of scholars and practitioners focusing on maternal and reproductive health issues and those focusing on social protection, and to try and create more of a dialogue, because we do think they've been quite divided. Just for people who come from the maternal and reproductive health side, just a quick overview of what we mean by social protection. Here we're really looking at a wide range of programs to support people not just living in poverty. There's a real focus on addressing risk and vulnerability, so addressing both economic and social risks and vulnerabilities, and the extent to which programs are able to help people be more resilient in their response to various economic and social shocks or stresses. So that would be the encompassing definition of social protection. What I've listed here on this slide are a range of different social protection approaches to supporting safe motherhood practices, just to highlight that we don't think that cash transfers are the only approach. What we're wanting to do with this piece of work with Interact was to explore the relative merits but also challenges involved in a cash transfer approach. There are a range of other different mechanisms, so the removal of user fees, as Una mentioned, but then also there's a range of community health and obstetric risk social insurance programs and voucher schemes that Leo is going to touch on. So cash transfers provide regular social transfers, as I've said, for vulnerable households. So it's often monthly or bi-monthly payments. The aim is to both mitigate immediate disadvantage, so to help people to provide for immediate practical needs that they might have, but also at the same time to be contributing to longer-term human capital development, so particularly investing in children's nutrition, education, and health. The focus, as many of you will know, of cash transfers has been on child well-being, but if you actually look at even many of the first-generation cash transfers in Latin America, which started in the mid-1990s in Mexico and Brazil, they also did provide benefits to pregnant and lactating women as part of the broader package focused on child well-being. And generally, this first generation of programs made program participation conditional on service uptake and attendance at various educational and awareness-raising programs. And as I've mentioned, we now see there's been a second generation of newer cash transfers specifically focused on safe motherhood, and I want to review what we know about both of those types of approaches. Okay, so in terms of thinking through the impact pathways as to how cash transfers might help address some of the risks and vulnerabilities that Una reviewed, I think essentially there are 5 main channels. The first is that many programs offer free care to incentivize service use. All of them are aimed at raising family income and opening up some financial space for maternal care. So rather than providing in-kind transfers, such as small livestock or food, for example, they're trying to give families some choice over how they use their scarce resources. Typically, though, the conditional strand of cash transfers have really set up some kind of social contract with women to ensure that they and their families are regularly, going to school, going to health clinics, using nutritional supplements. And as I've said, there's often an educational component, not only about practical matters such as sanitation, health, and nutrition, but often too about sort of intra-household dynamics as well. So you see that, for example, in the Colombian Familias en Acción program, for instance. There's a range of evidence looking at the way that cash transfers can also help raise women's status in the family, as mothers have typically been the main program beneficiaries. And then cash transfers, although not always, but increasingly they're also trying to address not just demand-side barriers, but also supply-side constraints. So often they are twinned with increased investment in, for example, health and infrastructure, and sometimes providing training or incentives for community health workers, and also incentivizing local governments with additional funding, as is the case with Brazil's Bolsa Familia. For those of you who are followers of the cash transfer debates, we all know that the jury remains very much out on the pros and cons of conditional versus unconditional approaches, and I'd just like to emphasize that this is particularly the case with safe motherhood, that the evidence base is very weak. Most of the programs have been conditional, but we don't really know if it's the cash or other parts of the program that make the difference, or whether it is the conditionality. So just to flag that. The pioneer cash transfer program was Mexico's Oportunidades program. Started out as Progressa, has switched its name as different administrations have come into power. But maternal health care has been one component of that. This is a program that's now reaching millions of households as of 2010. It's been very, very successful in terms of coverage. And here is one part of program conditionalities. Pregnant women are required to complete a prenatal care plan, obtain necessary nutritional supplements, and also attend health educational programs, both for their own health and that of their infant children. And it also provides related health benefits for lactating women and children under 4. So that's the famous Oportunidades. We also review in a recent background note that we've produced, and you can get copies of outside, the burgeoning array of other cash transfer programs that are promoting access to maternal health care. And so this is just a snapshot of programs in Guatemala, Indonesia, and the Philippines, but to say that there has been a considerable number of programs now in Latin America and Asia in particular. What's very interesting, I think, and says something about the political economy dynamics behind initiatives to tackle maternal mortality, is that while programs have contained a component to address safe motherhood, the evaluations have been much weaker in terms of assessing those impacts. So we know lots and lots about the impacts of cash transfers on child well-being. We know much less about their impacts on safe motherhood. And this is even the case with Mexico's Oportunidades program, which has a very, very robust monitoring and evaluation system, but there's still relatively little on what that program has contributed to safer motherhood. But with the evaluation evidence that does exist, while there are some mixed impacts, overall the picture is quite positive. So they are increasing the uptake of pre- and postnatal care. Women are more active consumers of healthcare more generally as a result of participation, and there's also increased maternal and infant vaccines and lower maternal anemia rates. And similar positive story coming from the El Salvadorian program as well. Okay, so the second set of programs I'd like to look at are cash transfers that have an explicit focus on safe motherhood. That is their overarching aim. And the largest and probably the most well-known is India's JSY program. I won't attempt to pronounce it. This is a huge program. By 2009-10, it was reaching 9.5 million women a year, amounting to 36% of the women who were giving birth in India. That was the latest government estimate. So it's a very large and important program. Its core aims are to ensure that pregnant women complete 3 antenatal and 1 postnatal visit, deliver in a public healthcare facility, and it's also trying to incentivize delayed childbearing and for people to have smaller families and better spaced families. And in addition, it's providing free care and travel expense for program participants, and is trying to additionally incentivize community health workers so that they can be supporting women to have deliveries in safe institutions. A similar initiative is Nepal's Safe Delivery Incentive Program. Initially, they also tried to make program involvement conditional on delivery in a government facility, but the subsequent focus has been on institutional delivery more generally because they realized there just isn't the infrastructure to deliver on that in terms of government services, so trying to look at a range of not-for-profit facilities as well. And again, there's a incentive component for healthcare providers, so trying to look at twinning the demand side and supply side incentives. Another very interesting initiative in thinking about, again, the point that Una ended with in terms of why should we care about these issues on International Women's Day and what kind of global collaboration do we need to look for, is this program that the Ghanaian Luxembourg Social Trust pilot. And this is a pilot cash transfer program in one district in Ghana. And the funding initiative is very interesting. It's through a global social trust mechanism, which is combining funding. 2/3 of the funding are from the government of Luxembourg, 1/3 from a Luxembourg-based workers' union, but then also in support or in collaboration with the ILO and the national partners in Ghana. So their broader LEAP cash transfer program, their national health insurance scheme, and then the Ghanaian health services. So it's a very innovative collaboration. They're still in a pilot phase, but I think that's a very interesting example to follow once evaluation evidence becomes available. And then I'd just like to briefly mention the program that we've been involved in with Interact. ODI was charged with designing the pilot program, then Interact with their local partners, rolled out the pilot in 2011 in Ethiopia, Malawi, and Uganda. This was a DFID-funded initiative. What was important was that it was also implemented alongside a broader program that Interact's involved with that includes involvement of community women's groups. So there was a strong focus on working through mobilized women's groups to raise awareness about the importance of safe motherhood practices, but then also to help distribute some of the educational materials. What we tried to do, and we can discuss the relative challenges involved with that, was we tried to design it so that the programs will be linked to broader mainstream social protection programs. So in Ethiopia, we thought about ways in which over time, if the pilot was successful, it might be able to be linked up with the National Public Works Program, Ethiopia's Productive Safety Net Program. And so there were two strands to the design. One was a conditional cash transfer, and this was conditioned on women attending 4 antenatal visits from the 2nd trimester, on an institutional delivery, or where that wasn't feasible, then at least attendance by a skilled birth attendant, and two postnatal appointments, as well as a bonus for complying with all of those conditions above. Then we also looked at an unconditional cash transfer where bi-monthly payments were made starting from the 4th month of pregnancy. And finally, in recognition of the much higher expenses of complicated deliveries, there was a complementary emergency fund to be managed at community level. Okay, in terms of the impacts of these programs, overall, the evaluation evidence from Nepal and India suggests that there is growing awareness about the importance of institutional deliveries. There's some encouraging results, but there are also a range of governance challenges. And some of the key challenges that the literature identifies, I think also our experience identifies around cash transfers, are as follows. First of all, there really has to be a lot of thought taken so that these cash transfers don't end up incentivizing pregnancy. And we already found that from some of the qualitative evidence in the pilot program that this was a real risk, and similar evidence from South Asia. So I think it's very important to be twinning these types of initiatives with incentives for family planning and birth spacing, etc. It's also very important to recognize that women are not making decisions regarding their reproductive health in isolation. Often other family members, their male partners, or perhaps mothers-in-laws have a strong say in what type of reproductive health services women have access to. So the sort of the social marketing or the behavioral change communication components of cash transfers you see in some countries, we think are really critical. Other challenges that emerge is that it's not just a matter of having cash, but also access to transport infrastructure. That was a major problem that emerged in Malawi, for instance. And then just thinking through that there needs to be, particularly in these low-income contexts where health systems are very inadequate, then they can become overwhelmed when you have a sudden demand-side push. And then there's also the literature, I think Maxine might pick up on this later, is that conditional cash transfers, at least, there's a lot of concern that they might add to women's time burden, and that they can also be complex and resource intensive to monitor. So what are the initial policy and programming implications that emerge from this review of the literature? So I've got 7 key points that I'll rattle through in the 2 minutes I've got left. The first is that obviously it's really critical to have a robust and context-sensitive vulnerability and needs assessment before embarking on these types of programs. It certainly can't be a one-size-fits-all type of approach. And we found that even working in 3 low-income sub-Saharan African countries with a great deal of variability in need and in service provision. It's critical that there's appropriate infrastructure around personnel, but also around processes and systems, even for monitoring the way these programs are rolled out. So I think those governance and administrative challenges are very real. Adequate and stable funding is obviously critical, and here we identified 2 areas, so donor funds for piloting and perhaps rapid scale-up of such programs once piloting has shown that the programs could be viable, but also it's critical to twin that with domestic funding so there's long-term stability and ownership. Conditionalities, if they are adopted, need to be carefully tailored, and I think we could have a longer discussion about that. And then we also think, and this is drawing on our broader work we've done also on gender and social protection more generally, that complementary programs are important. So it's also critical not to see cash transfers as a magic bullet, but also to be trying to establish linkages with programs trying to address poverty reduction, women's education, social status more generally. And then very, very important is the monitoring and evaluation. So the real need to ensure that monitoring and evaluation efforts are well resourced. Often they're very underfunded, and this has been particularly the case with safe motherhood initiatives and social protection. and often the findings are not well shared, and so there really hasn't been enough emphasis on lesson learning from both quantitative and qualitative approaches.
Nicola, thank you very much indeed. So any quick questions of clarification only on that one? Yes, if you could say who you are, and there is a microphone somewhere, you need to speak into it so the people online can keep up with us, so it's behind you. If you could tell us who you are, that'd be great.
Sure, I'm Catherine from Save the Children. I just had one really specific question on the Nepal scheme, in that it said that it was only available to women who'd had no more than 2 existing children, and I just wondered why they'd had that specific condition.
They have changed. The program has evolved over time, but at least some of the concern was around they didn't want to be incentivizing large families, so it's thinking through what are the incentives for birth spacing. But obviously then there's the flip side in terms of women with multiple births often are the most vulnerable or the most poor because they don't have that social status. So.